Hi everyone! Now we cross the Atlantic Ocean and we meet a young and very talented American dentist, Dr. Matthew Nejad. I am proud and very happy to have my friend Matthew with us to share his expertise about minimally invasive approach in aesthetic dentistry. Dr. Nejad got his degree from the USC California and is now USC Dental faculty in the Department of Restorative Sciences. He runs a private practice together with Dr. Kyle Stanley and Dr. Helm in Beverly Hills in California. Dr. Matthew Nejad is also lecturing in the hands-on continued education courses in biomimetic dentistry in California as well. I'm sure you won't miss a second of his lecture about functional rehabilitations using the adhesive minimally invasive approach, where Matthew will share with the world his experience and his protocol regarding this kind of treatment. Have fun! See you soon!
Hey everyone, my name is Matt Nejad, and today I'm going to be talking to you about a couple of my favorite topics, which are adhesive dentistry and complex restorative dentistry. The title for the lecture today is the Functional Rehabilitations Using the Adhesive Minimally Invasive Approach. And just a little bit about myself. I have a private practice in Beverly Hills with two partners. We have Dr. Helm and Dr. Stanley, and we've been practicing together for about coming on 5 years now, and the practice has been established for almost 70 years. And we do a lot of nice dentistry here, interdisciplinary, surgical, full mouth, general dentistry, cosmetic dentistry, and so on. We just went through a beautiful remodel, which was a lot of work, but it's been just like an awesome experience practicing with all the coolest technologies and doing like the best dentistry that we know. So I want to share some of that stuff with you today. I went to school in USC, and I was fortunate to participate in something called the Aesthetic Selective, which was a almost 2-year program that had advanced training in cosmetic, adhesive, kind of really the science and techniques to excel in adhesive dentistry. And I did a lot of cool cases. One of them I'm going to be showing you today is a case I actually did as a student at USC. And I got the opportunity to meet my mentor and get to know him well in this program. That's Pascal Monnier. He was like the most influential part of my career. When I met him, he inspired me to want to do better dentistry and really commit myself to providing the best quality, because dentistry can be a business, it can be an art, it's whatever you want to make of it. But after I came in contact with him, it was a no-brainer that I wanted to do this as a passion craft and make dentistry about kind of providing my best possible restorations and services to patients, something I could be really proud of. And that came from Pascal. And ever since I graduated in 2010, I went back to actually teach with him. So that's Kyle Stanley, Pascal, and myself. We are teaching this program. Pascal is the leader of the program. It's a course on morphology, and we have been teaching that course for the last, I think, 5 years, and Pascal's been leading that. Pascal, if you don't know or if you haven't heard of Pascal, he's like the most incredible adhesive dentistry researcher, lecturer. He has a book on cosmetic dentistry and biomimetic dentistry. It's called Bonded Porcelain Restorations in the Anterior Dentition, the Biomimetic Approach. And that's really the first time the word biomimetic has been used kind of in the mainstream. And I'm going to talk a little bit about biomimetic dentistry, but it's important to know that this is one of the first times it was used and the concepts were actually introduced. This is that course I was talking about. It's called Dental Morphology, Function, and Aesthetics, and it's really fortunate that every student who goes through USC in their freshman year gets to kind of go through the program and training of everything from what we call the 2D, 3D, 4D concept of learning how to draw and then wax up, and then 4D would be to actually do like color and depth, in other words, to do like a provisional restoration on the anterior that incorporates the 2D and the 3D and so on. So it's just a really amazing program, and we've seen a lot of students that have not only enjoyed that but come back and thanked us for teaching them this. My other mentor is David Alleman. I came into contact with David Alleman shortly after graduating, and he and I got along real well. He has the most incredible knowledge of adhesive dentistry, and as I'm going to show you, one of the things that I think that makes adhesive dentistry so complicated is that there's so many different products on the market. There's a lot of different opinions, but the thing is there's a lot of science too, and the science is very clear. The problem is not very many people have the time and the energy to read the science, but Dave is one of these guys who's actually read the science, he understands it, and when we started talking and sharing concepts and everything, we quickly realized that like this is what's necessary to make people understand these topics and be able to practice adhesive dentistry without a lot of the misconceptions that are out there right now. Together, Dave and I have been teaching courses on biomimetic dentistry for the past 4 years, and what we do is we do these hands-on programs where people come and we teach them everything from direct, indirect, teach them the science of adhesion, and that's been a great success. That's called biomimeticdentistryce.com. My passions, to sum them up, are basically adhesion, and you break that down for me into biomimetic and cosmetic both, and we're going to get through a lot of that today, but this is a typical case that I like to do in my office. So here we have a patient who has 4 existing veneers, and it's a little hard to tell from the before photos, but these were done a long time ago when she was younger, and there's been a little bit of recession or eruption of her teeth. As a result, there's margins that show, and also she was never really happy with like the contour and texture and so on of 7 through 10. So what we like to do is make these real nice, beautiful, very natural restorations, not the Hollywood or anything like that. And this is a case I did actually with Beverly Hills Dental Lab. And I do a lot of cases with them. They're actually one of our sponsors. I'm going to tell you about that in a bit. But this is the type of work that falls under biomimetic dentistry that I'm going to talk to you about. The before and the after. It's just all about beautiful natural results. For posterior, this is just some of the work that I do and post a lot on Instagram showing cases, but posterior biomimetic dentistry is all about, again, adhesion, saving teeth that would often be unrestorable, preventing root canals when possible, and also preventing posts, because the whole concept of adhesion replaces a lot of the need for mechanical retention, actually all of the need for mechanical retention. So we're going to get into how we need to utilize adhesive dentistry to replace a lot of the traditional principles. My 2 sponsors for this program are ADENT and Beverly Hills Dental Lab. And we're going to be showing a couple cases from Beverly Hills Dental Lab, and I'm going to show you my favorite products from ADENT in this lecture. So the lineup for today. We're going to start with an introduction, and then we're going to work our way to immediate dentin sealing, go over the literature on the functional full mouth rehabilitations using adhesion, and then I'm going to show you the whole technique with a case that I did. And during the intro and immediate dentin sealing, my goal is to kind of show you the science and the rationale behind why adhesive dentistry should be more utilized, and then we'll get into how it can be utilized by going through the literature and the techniques. So the question you want to ask yourself is, why don't we always pursue or try to do minimally invasive approaches on our restorations, because there's the old tried and true traditional prosthodontic way of doing things with mechanical retention, but what's the reason that we don't do adhesive dentistry and so on? And the reason is we are concerned about the strength of our materials / restoration. We have the concern of strengthening the tooth, the restoration, retention, because we don't necessarily understand the principles of adhesion and we don't trust in them. And then aesthetics, because with the minimally invasive approach, sometimes we're worried that we're not going to get the maximum aesthetics unless we prep more and so on. And all these are valid concerns when you are following the traditional approach. But when you can really grasp the concepts of adhesive dentistry and really get the right type of adhesion, you'll see that there isn't such a concern for these things. And the problem is that when you are doing the traditional approach, significant intact tooth structure has to be removed just to kind of fall in line with your restorative technique, and also to meet the requirements of your material strength and requirements. But this is all due to mechanical retention. And there's this whole paradigm shift where the mechanical retention, you need to understand that with adhesive dentistry, you don't need that anymore, and you have to just really understand the concepts and how they are going to replace that, and that's what we're going to go through right now. But adhesion is definitely the best way to restore the properties of a natural tooth. If you actually study the natural tooth and how it functions and how it works, you'll see that the adhesive restoration is the best way to most closely restore that versus a brittle, stiff zirconia crown or an alloy restoration, which are not at all natural or similar to how a tooth is actually behaving normally. Also with adhesion, we get the best marginal seal. It's also the most conservative, and it prevents unnecessary root canals, because by conserving, we can minimize our preparation. There's also this thing called the caries removal endpoint, which is a whole different topic, but by conserving and knowing when we can stop prepping, we can actually prevent a lot of the complications, such as root canals, that come from mechanical retention and minimum reduction concepts. Also maximum aesthetics. So that's what biomimetic dentistry is all about. With biomimetic dentistry, the goal is to copy the function, the biology, the aesthetics, and the mechanics of a natural tooth. And what we see is that all those concepts are kind of hand in hand. The biology, which is the vitality, gives rise to the function and aesthetics and the biomechanics. There isn't the aesthetics of a tooth is as a result of the morphology and the shape, which also gives rise to the mechanics and function. So we really need to understand the entire tooth and what it is we're trying to mimic, and that's what biomimetic dentistry means. It means to mimic what is natural. So first you have to understand what's natural, and then we want to mimic it. And a lot of studies are out there, but some of my favorite types of studies to try to understand the tooth are finite element analysis, which shows us how stresses are distributed in a tooth under different scenarios. There's strain gauges that again show us how stresses concentrate. Then there's cuspal widening studies, which can show us, the result of preparation of a tooth and what happens to the tooth in terms of deformation. And lastly, the histoanatomic studies, which kind of look at the natural properties of the teeth and the junction and the direction of the enamel rods, and they really help us understand what it is we're trying to mimic. When you look at all these things, though, you see that adhesive dentistry is the perfect paradigm for biomimetic dentistry and rehabilitations. This is a nice little excerpt I found from a engineering text on adhesives, and it says that the bonded structure is a safer structure because owing to fewer and less severe concentrations of stresses, fatigue cracks are less likely to occur. A fatigue crack in a bonded structure will propagate more slowly than in a riveted structure or even in a machine profile, because the bond line acts as a crack stopper. this is really important because it's talking about how a strong bond can prevent cracks from propagating, and it's the best way to have the least severe concentrations of stresses, and that's exactly what the DEJ does too. So we see that adhesion is the best for kind of restoring that. And for the non-believers, this is kind of a nice quote that I like that I got out of the Journal of Adhesive Dentistry, and it says, imagine a world without adhesion. What would happen if all of a sudden every adhesive bond ceased to function? Your post-its would fall to the floor, the windshield and many other parts of your car would detach, your tires would disintegrate, airplanes would fall from the sky, your boat, your high-tech bicycle, your surfboard, your tennis racket, all would fall and fail because fiber reinforced composites would no longer provide the strength that was intended. Even the soles of your shoes would peel off. Of course, dental restorations would also fail, leach, become unesthetic, etc. And the point of this whole thing is that adhesive dentistry is everywhere in our world, but when it comes to dentistry, we don't believe it's going to suffice. However, we use it on airplanes and space shuttles and all these things, and it really again comes down to the difficulty in grasping the concepts. And when we have the right concepts and the right techniques and understand the science, you'll see that it's totally possible and actually the best restorative technique out there. So bonding is an integral part of life, not just in dentistry. And the key here is that old habits die hard. We have to break these old habits. Here's a very interesting philosophy from Gordon Christensen that reminds me of how these old habits die hard. And it says that when you have a preparation into dentin, you have to make these lateral retentive features in order to keep your veneer from debonding. But that's kind of an old mechanical retention concept, because if you know how to bond to dentin, you'll see that not only can you bond to it, but you can actually get a stronger bond to dentin than you can get to enamel. So it all comes down to the right technique, and that's what we're going to get to in a second, called immediate dentin sealing. So this requires breaking these old habits, and we have the right materials already. So it's not that the material doesn't exist, it's really that our understanding has to be advanced, and we have the science there, but we just have to read it more, and that's our goal. My goal is to help you understand it, and Pascal Manier and David Alleman and all these other guys who've done all the research or are doing the research, we want to help you understand this so that you can apply these techniques more confidently. There's a lot of different products out there. Some of my favorites, adhesives, are the two-step self-etching systems, or the three-step total etch system like Optibond FL. Now, if we use these products and we use them right, let's say if we can get a bond strength of 51.5 megapascals. The thing that is very impressive about this is that would mean that 937 pounds of force would be able to hang from a 10 millimeter diameter surface. So if we're able to get a 51.5 megapascal bond to a 10 millimeter surface, then we can actually sustain over 937 pounds. But when you compare that to a lot of the figures that you see from manufacturers, or a lot of the weak bonds that people are producing, you'll see that it's in the around 10 to 12 or 13 range. So to get from 10 to 13 megapascals up to 50 plus, that is where you get into the range of biomimetics. Now, interestingly, if you look at the DEJ, so you take a human tooth, you take a slice of it and do a microtensile bond strength study, if you try to separate the enamel from the dentin, and there's a way to do that with notching the sample, you'll see that it actually takes 51.5 megapascals to separate human enamel from the dentin at the DEJ region. So this number is actually kind of our target. That's what biomimetic dentistry is about. Find what the natural property is and then try to recreate it. So we have the ability to get this bond, and that's the goal. It's to replicate the performance of enamel, dentin, DEJ, and to get this, we need to get that bond. Right now, our materials give us the ability to get anywhere between 40 and 70 megapascals if we use the right technique. So the key is the right technique, the right materials, and then we can get these bonds. Here's a couple studies that I also like. They talk about how the fracture resistance of a restoration depends on the bond strength. You know, the better the bond, or the higher the bond, the greater the fracture resistance. So when it comes to a single restoration or it comes to a full mouth rehabilitation, this extra bond, or getting the right bond, may make all the difference in changing your opinion of traditional prosthodontic principles to the adhesive approach. And we can actually even go thinner with our restorations, because if we get a strong bond, the whole system acts more as one tooth. You know, when you have a weak bond and you chew on that or you put pressure on that, the force goes through your restoration, but then it really concentrates at the weak bond. But when you have a strong bond, it passes through, so there's less severe concentrations, like I mentioned earlier. Here's a couple studies by Pascal and Louise Schlichting looking at how thin you can go. So, you know, Pascal's studies are always done with the technique that produces 50 plus megapascals of bond strength to dentin. And they wanted to test basically how thin can we go. Now, you know, we can get this bond, so how thin can we go with our restorations? And they first started by looking at restorations that were 1.2 millimeters in the central groove, and they had such good results and such low failures that they went on to look at 0.6. And the point here is that with a strong bond, even at 0.6 millimeters, you can get phenomenal success on your restorations, depending on the material, of course, which isn't the topic for today. But the key to know is that the strong bond is one of the key ways that your adhesive dentistry and your rehabilitations will succeed and last longer. So we want to minimize the need for reduction, and that's why the adhesive approach is the best. And we need to basically be substituting our traditional retention and resistance form with micromechanical and chemical bonds. So that's the philosophy. Now, the immediate dentin sealing, this is the key concept, because we all have the ability to get very consistent bonds to enamel. Bonding to enamel is actually very straightforward. A lot of the products on the market get similar bond strengths. Here's a great question for you guys. Which do you think has a higher bond, enamel or dentin? In other words, which one can we bond to with a higher bond strength? And a lot of people are going to jump and say, you know, enamel, because that's what they're used to, that's what's more predictable. They've heard that dentin bonds aren't stable or predictable. And the reality is, with the right technique, you can actually get bond strengths to dentin that are in the range of 40 to 70, like I was just telling you. But enamel, it's 30. It's easier, but it's 30. You cannot get much higher than 30 because of the properties of enamel and the brittleness. But dentin, because it's more compliant and flexible, if you can actually bond to it with the right technique, you're going to get a much higher bond strength. And that's what immediate dentin sealing is really all about. It's getting that strong bond to dentin. And what is it? It's the technique of applying your bonding agent to your dentin during your preparation appointment to freshly cut dentin. So at the time that you prepare, before you take an impression, you would be applying your bonding agent, curing it, and letting that bond to dentin form. And the question people always want to know is, why would we do this? Well, simply the reason to do immediate dentin sealing is to optimize or maximize your bond to dentin. This is how we get that bond. Because the minute you cure the adhesive, the bond to dentin begins forming. And a concept I always like to talk about is that bonds take time. You know, you cure with the light, you think that the bond is already done. You know, you think you're finished curing and that's it for your bond, but the reality is it's a polymerization process. it takes some time, and just because you finish curing doesn't mean the bond has finished maturing, and we do see that the bond gets stronger and stronger with time. Freshly cut dentin is the ideal substrate to bond to. So we want to look at some advantages of doing the immediate dentin sealing, and one advantage, there's actually a whole lot of advantages, there's whole lectures that are dedicated to this concept, but one of them is that dentin that is freshly cut is most ideal, and that's actually what you always see in all the studies. Any manufacturer, anybody that tells you about their bond strength to dentin, it's going to do it to freshly cut dentin. But when we go do an inlay, onlay, crown that's into dentin, we typically would prepare the tooth, temporize it, come back to it a few weeks later, try to bond to it, and there's so much stuff that happens there, and it's not going to give you the same bond strength. So number one reason is that we want freshly cut dentin when we're bonding to dentin, and that's only available at the time of preparation. Pre-curing your dentin bonding agent leads to improved bond strength. What does that mean? It means that most studies that evaluate the bond to dentin or look at dentin bonding agents cure the resin, then add composite masses on top of it. And that's actually what we do when we do a composite restoration. You put the adhesive on, you put your primer, your adhesive, you cure, then you put composite. But when you go do an inlay or an onlay, what's happening, or even a crown, is that you're applying your adhesive, and in most systems you don't actually cure that, because if you cure it, the thickness would prevent your restoration from seeding, right? So you put it on, you either air thin it or you don't thin it at all, and then you put on your composite or your cement and you put everything together. But what happens is that when you cure, the bond to dentin is happening at the same time as all the cement is also curing, and it's not giving the same bond strength. So it's known that if you cure the dentin bonding agent first, then add more, resin on top of it, then you're going to get a higher bond strength. And when it comes to our indirect restorations, the only way to get this advantage of pre-curing is to do it at the preparation appointment. I know there's some systems on the market that talk about air thinning and then curing, but honestly, if you air thin an adhesive and then you cure it, it's going to be so thin that it's all air inhibited. The air inhibited layer is up to 40 microns, and if you had to air thin something and then cure it, you actually haven't really started a polymerization process because it's so thin that nothing's actually cured. So that's not a very logical way to do things. We want to do it at the time of preparation. Immediate dentin sealing allows stress-free dentin bond development. So what does that mean? I already talked about how dentin bonds develop with time. It's not just dentin bonds, all bonds develop with time because it's a reaction. And during that time when the bond is forming, your goal is to let the bond form to dentin without trying to pull it away. You don't want to be having a lot of stress that separates the bond to dentin. And if you seal the tooth at your preparation appointment, and then you take your impression, you've allowed quite a bit of time for that bond to develop with no stress, and that does make a huge difference in the bond strength. We've seen that those bond strengths can increase over a period of 1 week, and there are studies that show that, and a lot of the advantages happen in the first hour or so. Up to 5 minutes we get a huge increase, but when we do our indirect restorations, we don't even give it a minute. We cure it, and it's being stressed immediately between checking occlusion, between the mass of resin or cement also polymerizing. There's a lot more stress involved in that scenario versus immediate dentin sealing. Couple studies that I like to reference here. These both show that the bond strength increases with time because the resin curing and the bond formation, it's a reaction. That's what I was trying to say. You think about a light curing system as you cure it and the reaction's done. But there's always the reaction continuing in the dark period, which means that there's going to be more polymerization happening even though you've stopped curing. And that's kind of more similar to thinking about a self-cure material, because you know that that takes time, but you think that when it comes to a light cured material, you have, you know, all the time until you cure and then boom, everything's done. But the reality is you've initiated the reaction and it continues with time. So one of the goals David Allman and I like to talk about is that you want to have at least 5 minutes of stress-free dentin bond to allow it to get to the highest levels. And that means if you're doing an inlay or an onlay or a CEREC restoration, you have at least 30 minutes. If you're doing indirect, you have at least 1 or 2 weeks. These allow that bond to mature to a much higher bond than you're going to get when you try to do regular conventional adhesive cementations. And when you do this immediate dentin sealing and you combine all the concepts I just talked about, you can actually increase your bond strength from 11-ish, 10, 11, 12 to 40, 50, 60, depending on the material and the technique and so on. And this is the study by Pascal Monnier that shows that same restoration, it's an onlay, same preparation, everything's the same. Only difference is one group had the immediate dentin sealing and one group had the traditional cementation where there was no immediate dentin sealing, and the difference was just remarkable. And this is the technique. This is the part where I'm saying that this will help you do restorations and full mouth rehabilitations more confidently, knowing that the adhesive restorations will last just as well, if not better, than traditional approaches, with the advantage of saving more tooth structure. So that brings us to literature on the topic of functional rehabilitation. So these were papers by Francesca Violotti that talk about the 3-step approach to restoring a severely eroded dentition. It's an approach that you can actually apply to any case that you want to do with the adhesive technique. Traditionally, doing an adhesive rehabilitation would be a lot more difficult because of provisional restorations and sequencing and worrying about complications during the temporization period. But this article does a great job. These 3 articles actually do a great job of going through the technique, and I do something very similar. I'm going to show you one of my cases, which is an adaptation of this technique, but I wanted to go through this. And if you hadn't seen this same topic was covered by Francesca just a few days prior during this Congress. So in step 1, it gives you the kind of introduction and the principle, and the concept is that the adhesive approach aims to avoid this excess preparation and endodontic therapy required for mechanical retention, especially in a erosion type scenario, because you've lost so much tooth structure. Now when you go to prep and get mechanical retention, oftentimes you're talking about intentional endodontics, you're talking about post and core, and then crown and bridge. So the goal is, how do we avoid that? And I read this paper in 2010 and did a case at that time, and since then I've been doing exclusively these type of rehabilitations, and I think that this article does a fantastic job of kind of laying the framework for it. So Francesca breaks it's Francesca and Ernst Belser, who was actually a mentor of Pascal's, and they break it down into these 3 steps. So the first step is the aesthetics, establishing your aesthetics. The second step is getting the posterior support and kind of testing the function and the vertical dimension and so on. And then in step 3, it's to add the anterior function, the anterior guidance, canine guidance, etc. So the purpose of step 1 is to test the aesthetics, determine your occlusal or incisal plane, and then to go from there. And what she did that was really unique was she broke the wax up and planning into several segments. Instead of doing a full mouth wax up all at once, she chose to break things up into one segment at a time, step one, and then the lab does their part, and then you do your part, and then it goes back and forth. So it's a really interesting approach. So it starts with the wax up of just the facial aspect of the front 6 to 10 teeth, depending. Oftentimes 8 or 10 is ideal to really kind of get the full look, because you're going to get this wax up. The goal is to have no change in occlusion at this point, or no change in the lingual or occlusal surfaces, so that you can try it in on the patient. So here we have a patient that Francesca worked on, and what you see is the before on the left, and then you see in the center a provisional restoration called the mock-up, which has 6 teeth treated. And you can kind of tell that there's like a little bit of an awkward transition. In the article, they mentioned that the patient felt like this was a little bit too long, and wasn't really thrilled about this until they showed the next one on the right, which was an 8-unit mock-up that kind of gave the full picture. So that's why I say oftentimes 8 or 10 is an ideal. That's actually a 10-unit mock-up there. The ideal is to be able to show the patient what it would look like with acrylic and get their approval, and then make any changes as you see fit, and then move on. Here's another case looking at the same thing, and we have, I think it's 8 units on this case. And the idea, again, communicate with the patient, show them what you have, learn. This is a great way to kind of make changes before it's too late and really get the smile perfected. Then you want to proceed to step 2, which is to test the function, open the vertical dimension, and establish the posterior support. The traditional way that this is done is, well, one of the traditional ways that this is done is to use provisionals. Another way is to use a removable like occlusal guard type appliance and have the patient wear it, but compliance becomes a big issue if you're trying to test a new vertical dimension this way. So what you want to do, and what she proposes in this technique, is now you have your lab finish the wax ups of the occlusal surfaces of all the posteriors except for the terminal molar. And I'll show you why in a sec, because you want to make a clear putty of the wax up, but you need to have a stop for your putty in the anterior and the posterior, so that you can actually use this putty to make provisionals for the patient. And the posterior tooth, the last molar, acts as a stop so that you can seat the putty and have like a very accurate replica of this wax up. And what you're going to want to do when you do this, so in their technique they use the composite in the mouth. So I like to use a calcet warmer when I want to use composite, especially for cementations. When I use composite, which is part of the technique that I use all the time, heating the composite makes it a lot more flowable and less viscous, so you can work with it. So in this technique, you take the clear putty that's based on the wax up and you fill it with composite, and ideally warm composite so that it's a lot less viscous and easier to seat. Then you take it into the mouth and you bond it right in. So you can actually bond this composite right onto the tooth. They're going to be connected and splinted, and you get something like this. The picture on the left shows you how the splinted composite restorations look, and then on the right you can see Teflon tape packed into those embrasures so that not much excess gets in there. So that's a really good way to prevent like a lot of composite getting stuck, and the patient can still clean this with super floss and a water pick and so on, but they can't floss through it like normal. So that's just one of the limitations, but the benefit of this technique is that you can actually test the vertical without the patient having any issues of compliance. There are several cases that go through this. What's amazing is how nice it looks, and with just a little bit of finishing and polishing, you're able to get like a really nice result and a really nice stable posterior occlusion. A few other cases. Now, the terminal molar is not treated, first of all, which we mentioned, And the other thing is that if you have existing restorations, you have the choice of taking out the restoration and then doing this, or during this step, you can just place it right over. Of course, when you go to the definitive stages, you'll be replacing, any alloys or any previous restorations. But for now, since you're just testing the vertical, you can actually do these on top of other restorations without replacing them. So at this point, let's go back here. So at this point, we've tested the anterior. You kind of have an idea of what the patient likes. You know where you're headed. Now you're just trying to kind of create the space to achieve that, and that's what step 2 is doing. It's giving us the vertical dimension we need so that we can restore the anteriors that way, and so that we have a good stable occlusion. Now we can test it. How long you test for is something that's perhaps up for debate, but anywhere between 1 and 2 months seems to work really well in my hands. And you can evaluate symptoms, make adjustments as needed during this time until you find something satisfactory. Then you can proceed to step 3. I'm going to show you my techniques just a little bit different, because at this point when you're testing, you have no anterior guidance, no function. I like to have that, because the few times that I've gone without that, the patient was less comfortable and complained about it. So I find that skipping to step 3 a little sooner, like in the first week or 2, or sometimes even right away, is actually a better approach for me to test everything out a little bit quicker and give them the guidance and anterior function. So that brings us to step 3, which is to establish that anterior guidance and the anterior contacts. Because up until step 2, you haven't actually established that. You had the facial, you had the posterior occlusion, and now it's time for getting the anterior lingual surfaces restored. So here's an initial case on the left, and on the right side, this is the patient biting down, but what you're looking at is they have no provisional on the front teeth, and their posteriors are at that new vertical, so they have this like anterior open bite until the teeth are restored. And to restore the anterior teeth, we need to restore both lingual and facial to get function and guidance, especially since these are erosion cases that this article is kind of going through. Now the problem is, with the traditional approach to restore that tooth, you're going to have to take off pretty much everything that's left to get retention. When you look at the shape of an anterior tooth and it's like fan-like shape, you have to take away so much healthy tooth structure to restore facial and lingual. If you're only doing the facial, you could do a conservative veneer prep, but when you want to go restore facial and lingual, that requires a path of insertion, which requires a lot of reduction, and it's just really destructive. So if you look at what's left on a erosion case like this, you can see that there'll be very little enamel, actually no enamel left by the time you prep for a traditional retentive restoration. So what the solution is to do a facial restoration and a palatal restoration, 2 separate restorations to restore this. And the material of choice for the palatal would be composite and the facial would be ceramic. So that's what this article kind of starts talking about in the step 3. And they say that there's 2 options. I like to do option A, but the 2 options are to make this palatal restoration at the full length that you've planned in step 1, or to just focus on getting the guidance and keeping it shorter for now, and then restoring the length in the final restorations that we're going to get to in a second. I like to do A when I do these, and what you do is you have your lab make these composite restorations, and you want them to add this little hook that you see in this picture, so that as you're seating it, it kind of helps seat the restoration, prevents it from sliding off, and then once you've had it bonded in place, you can actually remove that, polish it down, and you had like a very predictable, easy cementation and the advantage of proper positioning, and it's just like the perfect way to take care of this. Before and after. So after this stage, the patient's going to have, increased incisal length. They're going to have the full palatal surface restored, and they would look like the picture on the left here with the yellow palatal restoration that extends to the incisal. And then when you go to the final restoration, you would prep away the composite, replace the facial and the incisal with ceramic, and you have what's called kind of this sandwich or bilaminar technique. Some people call it sandwich technique, some people call it bilaminar, but the idea is you can kind of get away from the traditional prosthodontic retention form like on the far right over here by doing a sandwich restoration, which is getting the facial and lingual separately, and you've got a strong bond on both sides. You've preserved the tooth structure. There's really nothing more important, in my opinion, than preserving healthy, intact tooth structure, and you're able to do that with this technique. So that concludes those series of articles, and now that is kind of the baseline for how I do all my cases. So in this next phase, we're going to go through my technique that is slightly modified, and every case is a little different, so I do modify case to case, but I want to show you kind of how I like to do a functional rehabilitation using these key concepts. So the basis of my technique is these articles that we've covered, and I'm going to go through this case now and show you how I've modified it and some of the things that I found to be kind of working better in my hands. So I still do all the steps, but the way I combine them is just a little different. I do always test the anterior. We want to know how it looks before we commit to anything. We want the patient to have a chance to get motivated and see that and kind of be on the same page. Nobody likes, having their final restorations being a surprise to them. So even on the smaller cases, I do this mock-up technique, which I'll show you, but especially on a big case, you have to establish the length and the shape and the correct occlusal and incisal plane. But then I go to the testing of the vertical, and I do it a little bit differently, which I'm going to show you, and I definitely want to get the function part of the anterior also restored, so I like to have this done kind of hand in hand with step 2. And then we have the step-by-step restoring. So when it comes to finally doing final restorations, we can do the anterior finals first and then the posterior finals after. I've done it both ways. It depends on the case. There's pros and cons to each, but as long as you have the patient in stable vertical dimension and stable posteriors, you can actually restore the anteriors first. Sometimes you actually might not want to because it might be hard to finish the case without kind of keeping that for last, but it's certainly a safe way to proceed. So as I mentioned, I did this aesthetic selective, and this was a program that I got to work with Pascal for almost 2 years, and it had a lot of clinical experience, but it also had a whole year of a classroom setting where we went over a lot of adhesion and principles, and I got to do this really cool case, which was a full mouth rehabilitation of a severely eroded dentition, and this is where I learned kind of a lot of the concepts that I apply in my practice today. So the patient had a previous history of bulimia, and as a result there's a lot of acid erosion. Her premolars look a lot like a canine with the whole lingual eroded away, and the challenging thing on these cases is that what's left of the tooth is significant, but by the time you prep, there's very little left. And to get a perfectly ideal cosmetic outcome and also a functional outcome, it would be ideal to minimize preparation and build on top of it rather than prep more and result in the root canals and all the downsides we've talked about. So this is the basis of this type of adhesive approach, and you can see on the palatal surface of the upper restorations or the upper teeth there is severe erosion, and by the time you were to prep for crowns, you would have nothing left. So what we do on these cases is this full mouth approach, and the first step for me is to have an idea of how much I'm opening the vertical dimension, and I determine this using a couple different things, but oftentimes it's looking at the cast, looking at how much space I need in the anterior, and kind of opening on the articulator, then coming back in the mouth and calibrating that. So I'll make a jig. In this case, we have a jig of about 2 millimeters of anterior opening, trying to stay always as minimal as possible. I don't want to do more opening than I have to. I find that it's a lot better to tolerate a smaller opening or a minimal opening, and like 2 millimeters in the front would be, you know, about a third of that in the posterior. So we get this and try it in, make sure we adjust it and take a look to make sure it's consistent. And then we place by registration. Now we can remount the casts at that. So we start by making it on the cast, and then we come back and remount with the proper clinical records. And then I go straight to a full mouth wax up. And a lot of the reason I go straight to the wax up is nowadays there's actually a lot of tools that help us plan these things. There's digital smile design, and I was using Photoshop for a long time too. With very careful planning, I feel I can get very close to the length and shape and so on. And if we want to make some shape changes to the front, that's actually not a problem. The key thing is having a good understanding of where the ideal incisal plane is going to be and the ideal occlusal plane is going to be. So if I plan that carefully, we can actually go through the full wax up at the beginning, but still proceed step by step, and I'll show you how that works. So here we have the final wax up of the upper and lowers, and we got full anatomy and everything. It's primarily, or actually entirely, additive because we're trying to restore what's been lost due to erosion. So if you look at this, you'll see how it is before, and then kind of how it morphs into the final situation with the increased vertical and all the anatomy restored. So step one, as before, is to test the aesthetics, and I call that the anterior mock-up. And how that works is we have our wax up and we take a silicone putty of that, and in this picture on the left, what we're looking at is two things. We're looking at how much space we have, because when you want to do this mock-up, you have to have space. So as long as it's additive, which means that you're adding volume, you can do that. And in most cases, that's not a problem. Obviously, there's exceptions to that, but most of the time we can go slightly bulkier for now if we have to, with the idea that as long as we have a little bit of space, we can test this out and make sure that the outcome is going to be something that meets the patient and our expectations. And you'll see there's a little bit of rope wax, red rope wax in the undercuts in the contact areas. That's to prevent too much acrylic from flowing in, because I'm not bonding this acrylic in. What we're doing is we're letting it lock in a little bit in undercuts, but not so much that it's going to be difficult to get out. So we take this acrylic, and I'm using New Outline, which is a beautiful acrylic system by Michel Monnier, and it has just the most amazing aesthetics. It can look amazing. It's highly polishable. You have a lot of different shades, and I think it looks the best. It's also among the most durable temporary materials because it's a PMMA. So we do this, we place it in, and we can either get no excess or very little excess. So here on the left, you see how there's a little bit of excess acrylic covering the gingiva. And what you want to do there is clean it up with a diamond, and there's a few different techniques here, but the best technique to clean that up without causing any trauma to the gingiva is to use an electric handpiece. We have a lot of control with the electric handpiece, so you can go at like a steady speed, and then what you do is you do kind of a pecking motion, pecking right at the gingival margin, trying to thin the acrylic out. If you run side to side, you run the risk of kind of catching and cutting gingiva, but if you're careful, I've done that as well. So it's actually not as hard as it would look to clean this up without, causing any damage. But you would go around, clean that up, and then you just stain and glaze. So the result you see on the right side is just simply staining and glazing. Now this provisional is more than one shade, but it is monolithic because it's all mixed together. So it's one massive material. There's no cutback on this, but it still has like a really nice natural result just from staining and glazing. We did a little bit of interproximal stain to kind of create separation. We have a little bit of incisal stain to create the translucency effect, and just a little bit of cervical to kind of blend in with the gingiva and have kind of a nice transition. So this is a 6-unit provisional mock-up to test, and we have the before and after. Now, if I could go back on this case, I would probably do the same mock-up with the front 8 teeth so that we don't have the bulgy appearance of the canines. But in this particular case, the patient was happy with the result and length and didn't require that. But more and more, if I feel like we're adding significant volume, I would always say to go ahead and do 8 or 10 teeth so you can really get that motivational aspect going for the patient and get them to really be excited about the case and the outcome. This is the perfect time to take photographs and do an additional smile design if needed. Any modifications can usually still be made right now without any problems. So once we test this and we're happy with it, now it's time for step 2 as before, which is the functional vertical dimension and testing that. So in the approach that I do, I rely a lot more on indirect lab support, having things made not using my chair time and being ready to deliver chair side. I find less cleanup and the extra cost associated with that for me is worth it. So in this case, we had these beautiful posterior mock-ups. You can call it posterior mock-up or the posterior splint, but basically we had these thin composite ready to deliver splints, and we just had to try them in, make sure everything's good, verify our vertical, and go ahead and cement those in. So here we have rubber dam in place, and we go through our normal bonding protocol. Now at this stage, the bonding of this material, you have 2 options. You can be rather conservative with your adhesion, knowing that later you're going to take it off and rebond. Or you can make sure you get the strongest bond now, and then later when you come to prep, any composite that you leave behind can be part of your base. As long as you have the strongest bond possible now, you don't have to come back and remove it all, especially not in the DENTIN area where it's not going to be on the margins or anything. So you have your choice. Now what we did is we cemented this with Optibond FL. We didn't even use a cement per se, so we did our etch, prime, bond, and we actually cemented using Optibond FL in this case. Usually I would use composite, but there was so little space and this was on the thinner side, so we wanted something that was a little more fluid-like and even less viscous, so we used the Optibond FL here. Other times you would use the Calcet warmer, which I talked about, which heats up the composite and makes it very easy to cement, except in this case there was 1 or 2 areas where it was so thin that we worried that the pressure might cause fracture. So this is that Optibond FL going into the restorations, and we put it in, verify that it's in place, and then we go ahead and cure. Those wedges that you see there are to prevent, just like the Teflon tape before, it's to prevent any excess from flowing into those embrasure areas, and it really helps minimize cleanup and make sure that the patient can actually access this area for cleansability. Because look, at the end, it's going to be up to the patient to, do their part for hygiene. But if you don't give them the opportunity and you have it blocked out, then it's going to result in recession and complications. So you have to have a cleansable scenario and then make sure the patient's on board with maintaining this. There's also a technique that I've been using lately where you can make these as individual restorations, of course, but with CAD-CAM, the cost comes down. You can actually scan your wax up and have individual CAD-CAM restorations, and you can cement them in, and you don't have to spend too much time cementing, because the whole idea is this is the provisional phase. So you can cement it in rather quickly with CAD-CAM restorations that are individual and get the benefit of cleansability. So that's another way I like to do this as well. So here you're looking at the final upper and lowers, and sorry, not the final, but the final of this step. You have the posterior mock-ups in place. They look really nice. I mean, it almost looks like final restorations, but remember, they are connected. And another thing that's nice to notice is during this step, we did go ahead and add the volume onto the premolar areas of the uppers, so that you can kind of get the effect of the final result, whereas in step 1 we didn't have that because the canines were a little bit bulgy. So we get a lot more of the consistency, and you can see that coming up here in the smile, where it doesn't look like there's a big transition from canine to posteriors. So another good opportunity to take photographs and so on. Now, normally you would, in the traditional Vialati technique, you would wait a month, and she says she doesn't have any major complications. Waiting about a month, for me, patients were more likely to complain about the speech, and where I'm at, it just doesn't make sense for me to leave a patient with an unrestored functional aspect at this point. I would rather go ahead, because everything we do is reversible. If I want to prep those off and make new ones or make adjustments, we have a lot of flexibility. So I go into step 3 much quicker. Sometimes immediately after, like 1 week after putting step 2 in, sometimes even within the same appointment, depending on the patient and the time we have. But the goal being to get step 2 and step 3 completed, so that they have full functional ability to test. That means they have the new vertical, they have the ability to test the anterior guidance and the function and everything during this phase. Now I want to keep them here for 1 month. So in step 3, just as in the Vialati technique, it's time to restore these palatal surfaces. Now, the thing we had talked about before, to get this strongest bond to dentin, you want to do the immediate dentin sealing. So when you look at these preparations here, or like the existing teeth as they are prepared, there is a lot of dentin exposure. So first thing you do is you freshly cut the dentin so it's clean. You're just kind of removing the surface. You can also air abrade it. Then you do your etch, prime, bond. In this case, we're using Optibond FL. So we're doing the steps of immediate dentin sealing right now. And that is our preparation. The only other thing you need is minimal separation between the contact areas, but that's it. So our final preparation is just that immediate dentin sealed area. We take the impression, and then we have the lab create, again, just as before, these composite restorations. And in this case, we did not only the canines, but we went up to the premolars to restore them with this composite palatal onlay, so that later, when we come back to those premolars, our preparation can be a little more conservative and not have to be more like a crown or a wraparound. These hooks, as I was mentioning before, these hooks are like the best way to cement these, because without the hook, like when 1 or 2 of these break off, much harder to position things accurately. So you want to make sure, if you're doing these, you plan some sort of notch to make seating of these into the right position more predictable and easier to deal with. So your lab can do this for you. It's not a big deal. You just have to make sure you specify that you need this to help you seat these restorations. and we go ahead and go through the bonding protocol. So my bonding protocol in a nutshell would be to use composite warmed up. And now that we have this immediate dentin sealed layer and we come back to cement these restorations, what you want to do is aerobrade to clean the surface and roughen the resin, because aerobrasion is really the best way that you're going to be able to bond composite to composite, and it can actually create like a very strong bond. And so you aerobrade, then you come back and you etch everything, especially the enamel, and you rinse it off, you get everything clean, you apply adhesive only at this point because there's no more dentin that you're trying to bond to, so you can apply just the adhesive, and then you apply adhesive to the restoration as well after you've conditioned the restoration, and you're going to use composite, and you just gotta apply pressure and clean. So here's the cal set. And as we're seeding it, we'll be pushing and getting excess cement out and everything. And once it's fully in position is when you want to cure. And that's the technique that I use to cement these. And it gives you unlimited working time, because when you use composite, you don't have to worry about it setting on you if something doesn't go well. If the restoration isn't seeding, you have time to figure out what's going on and still make sure everything gets into place. And also, nothing's better than composite on these restorations because it gives you a margin in composite. It gives you the strongest bond because the modulus of this material helps create a stronger bond, and very polishable at the margin. So these are all good reasons to use composite. And by the way, cleanup is actually like a lot easier than using Panavia or something like that. So whenever I can, I like to use composite and minimize using traditional cements or resin cements. So here's some of those steps going on. We have the tooth that's aerobrated on the left. Here's the tooth seated and prior to curing, cleaning up as much excess as we can. And when everything is done on this case, we have this beautiful result. Everything is cemented nicely. It's actually bonded with that 50 megapascal bond that we talked about. So it's the best, strongest bond we can get. So that's where the immediate dentin sealing comes into play. Now, let's go back just for a second again. At this step, the patient has the anterior step 2 completed, which is having the palatal surface restored. They have the posterior mock-ups in place that we created in the previous step as well. So there's everything done. It's actually step 2 and step 3. So step 2, posterior mock-up. Step 3, the anterior palatal mock-up, and they can test their full function. I would normally keep the patient here for about 1 month and have them come back for adjustments as needed. Let me know if something feels uneven, something feels uncomfortable, and if everything looks stable, comfortable, and consistent, we're ready to proceed. And you can actually go to the posterior first or the anterior. In this case, we went to the anteriors. There's some lab preference to this too, because there's a lot, some labs will tell you that they'd like to get the first dialed in perfectly, make some final adjustments as necessary, and then they can adapt from there. But if you have good planning and everything, I think it's okay, and I've done it many times. Restore the posteriors and wait for the anteriors in the last stage. So this is the patient at the stage of step 3 with the posterior mock-ups and anterior mock-ups. And since I added length with those anterior mock-ups, you can see that the result is actually significantly improved as it is. And it's interesting to note that, like, in some cases, you might just be able to, work on a little bit of facial composite work at this step and be done. You don't always need to go to ceramic on the facial on these cases to get the desired outcome. So here she is with just that incisal lengthening and palatal surface, and you can see it's already a dramatic difference versus how she started. So we did something more like the letter A that you see here with the full proposed final length. And then when we do go prep, we're going to go ahead and prep down back to the incisal edge, and then we're going to leave that lingual composite right where it is on the palatal, and that's going to be part of our sandwich or bilaminar technique to prevent over prepping. Here I'm checking with the putty that is based on the wax up to look at how much space I have. And when I do the anterior preparation for veneers, what I like to do is place the mock-up back on and then prep through it, so I know I have exactly as much reduction as I need, because how do you know you have enough reduction in the cervical or interproximal or anything like that? The best way to do it is to put your mock-up in, and then from there go ahead and prep right through it. So here the mock-up is going in. Let's go back to that. So the mock-up is in here on the right, and we don't have to worry about cleaning up the gingival margin or anything. We go straight to making some lines in the cervical areas in the middle third, and then using diamonds that are calibrated. So we use like a round diamond, and we can go ahead and use it to sink all the way up to the shaft area, and then we know the measurements. Like here we're making a 0.7 millimeter reduction on the middle area. We can do a 0.3 millimeter reduction in the cervical third, and we just go through prepping this way and getting a very calibrated reduction only where we need it. So if the provisional was already thick enough that we didn't actually touch tooth structure here, that means we didn't need any preparation there. So it's a great way to make sure you have exactly the reduction you need, and the result is a super conservative, very conservative preparation, which is the best in my opinion to prevent problems. A lot of patients these days want to have this, and really there's nothing better than preserving this tooth structure, and I think that's the best way to get like this long-term success. Final preparations from the occlusal view, and now we restore the anteriors, and then we can work our way step by step. So at this stage the anteriors are restored. The posteriors are in the mock-up, so we still have our vertical established, and we can go quadrant by quadrant to restore. So that's the next step. So now I will do upper arch or lower arch or right side or left side. I usually like to do right left to maintain the vertical, so I'll do the right side, finish that off, either 2 quadrants or 1 quadrant at a time. I like to do 1 quadrant a lot of the times. One appointment, finish 1 quadrant, move on, and it's just a great way to proceed. We can use a little bit of a silicone putty to check our reduction again here. So we can make our posterior reduction again calibrated, prep through the mock-up, of course. So we have this mock-up in place. We can prep, make our reduction grooves, and then check it with that putty to make sure we're not shy anywhere. So another great way to get the ideal preparation without over prepping. These are the restorations. These are the provisional restorations that we make. So at this stage, I'm going to go back to that real quick. At this stage, when we have the final preparation, I either have a indirect provisional I make myself or a shell provisional that the lab has made for me that I will reline. And I reline it with acrylic. For this, I would use, again, either new outline if I'm doing indirect, or jet acrylic if I'm going to go intraorally just to reline, because it sets a little bit faster, especially the fast set version. So here's these provisionals ready to go. These ones were actually lab fabricated, and we just relined them. And one of the things with these non-retentive preps, actually there's a few tricks I've learned, but one of the tricks is to make sure that you have like this notch or bulge area right here that kind of engages and gives you a little bit of a snap fit. So it has to come around and give you a little bit of retention. And the other way is to use a strong cement. At the time we use Tempon Clear, but you don't want it to stick to your immediate dentin sealing. What I like to use now is Duralon. It's a great cement to use for the provisional. If you've done your immediate dentin sealing, it'll stick to it, but not to the point that you can't just sandblast it off or chip it off. But it has really good retention, and it really helps these provisionals stay in at this stage. So we get the provisionals in, and these are the final restorations coming back from lab. So at this, what's kind of the beautiful thing about this approach is you can actually restore one quadrant at a time and maintain your vertical and not have to worry about the provisionals. Because the thing about these provisionals that are in the posterior mock-up, so like on the side that you haven't touched, you have a very stable occlusion. With these bonded provisionals, you don't have to worry about provisionals coming out all the time. So the only side you're worrying about is the side you're treating, but the vertical is not messing with you. It's not actually having issues, and it's very stable. Here's the final restorations that are on the model and in the mouth. Close-ups of these final restorations. These are done by Michelle Monnier, and a lot of this, actually this whole case was done by Michelle for the lab work. And here's the final completed upper. And at this stage, it's been about 1 year, and the patient is in these lower provisionals, which are those bonded mock-ups that we talked about. And you can see that there's been a little bit of wear, but everything's holding up like very nicely. So it's not something that we had to replace throughout the whole duration of a year. That stayed in place, and we didn't have to make any changes. And from this point, you could continue to restore. So we finished the upper arch in this case first, but nowadays I would actually do the quadrant by quadrant, right side, then left side, and that way you can maintain your vertical much more easily. What we did here was one quadrant at a time. Final completed upper. Some various photos we're looking at here of the final. Now, I want you guys to all stay connected. I have 2 Instagram accounts. My personal Instagram is Dr. Matt Najad, and that's where I post a lot of anterior cases and cosmetic cases. And then I have a lot of awesome cases on biomedic CE. Those are like inlays, onlays, and margin elevations, which is a concept we didn't talk about today. So follow me on Instagram, stay connected. I'd love to hear from you guys, and have comments on some of these cases, and work with you guys. And then I'm going to be doing 2 courses next year. If anybody is interested in kind of learning more about these techniques, I have an awesome anterior course. It's going to be me and Michelle Monnier at Beverly Hills Dental Lab. And it's going to be 3 days, everything from start to finish on how to do veneers and cosmetic dentistry from the wax up and planning stage up into the mock up and trial stage, and then the provisionals and cementation, just the full technique start to finish in 3 days. It's going to be like an awesome course to learn all these concepts and work with Michelle Monnier on the aesthetic side, and I'll go over all the science and techniques that I'm using all the time. Let me go over the dates for those. So we have May 24th and 26th, and then November 8th and 10th. And then my biomedic dentistry CE courses, which I have twice a year, are 2 days and 4-day courses that are really kind of focused on teaching the science and the techniques for routine inlay, onlay, margin elevation, adhesive dentistry. And we have these 2 courses. We have June 22nd through the 25th, and we have October 5th through the 8th. So I'd love to see some of you guys there, and take a look at the website at biomedicdentistryce.com. It's been a great pleasure, guys. I hope you enjoyed all this, and get in contact with me if you have any questions. I'd love to hear from you all, and have a great day. Bye.